Can I just ask you one question there? You said that you had a 10% failure rate.
Yes.
Would you expect a 10? I mean, you said there were various reasons for it. Does that mean that you think that a 10% failure rate is about as good as it gets? Do you think it's possible to push it, or does it take too much effort to push it to make it better than that?
No, I don't think. I wouldn't want to be one of those 10%.
No, that's true.
So
Okay.
I don't think it's.
So the answer is push it.
Push it.
Okay.
And keep pushing it.
How do you use an NNT for clinical decision making? Do you use NNTs for clinical decision making?
Yes, I'm aware of them, thanks to your work with Cochrane. And I think their value is in it enables you to choose the agent or combination of agents that you feel are most likely to succeed here with acute pain. So that's the first chance. But what's so important, if we have an NNT of 2, what we're saying is that 50% of the time it may not give us the success we want. So first of all, it tells me that's the best, so that should be the first choice, but it reminds me that some of the time I'm going to need to do something else as well.
When you're treating a pain which might come and go, that could be acute, or maybe it could be acute and chronic, should NSAID be used when there's no pain, or should they be continuously used?
No, I think we need to try and we need to be very careful about chronic use of all of these agents, because as has been pointed really by the question, very often the pains go and then that's fine. So, but your NNTs beautifully put there 50% pain reduction for 6 hours, within 6 hours. So if you've got a pain that's going to impede what you do, I certainly think we should be considering taking them. But we need to shy away from using these things for weeks on end.
Yes. So the lowest dose for the shortest possible time,
Perfect.
which is the sort of advice that's used anywhere. And this is perhaps an associated question. I'm not quite sure where this one comes from either. And whether or not, for example, in the example that you used, do you use a fixed dosage regimen to the PRN?
Yes, certainly. Whilst patients are within a hospital, it should be a fixed dose to ensure that they're given.
In other words, don't wait for the pain.
Don't wait for the pain. Try and get on top of it. Certainly in the first few days, absolutely. And try and empower the patients. There should be something available for breakthrough pain. It's usually a severe pain, so you would expect something quick acting and strong. But there should be something available that's given preemptively almost.
And would you have somewhat different regimens for different types of surgery? I mean, you know, if somebody's having a hip replacement or a little finger operation, as it were, you'd use different analgesics. Well,
you would do, and it
regimens.
Also depends slightly upon what the anaesthesiologists will have used, because very often for the simple things they might put in local anaesthetic blocks, in which case that buys you a bit more time post-operatively to get on top of your analgesia. So it's back to the multidisciplinary approach. It's the team event. It's the surgeon. It's the anaesthesiologist. It's everyone knowing what's going to happen. It's the nursing team, and it's the patient, and they all need to communicate.
Okay. What about injectables? What about injectable NSAIDs? I mean, the question here is very direct. I'll ask it to you. In acute pain, the most common used injectable is diclofenac in the Indian continent. Is it true also globally?
I'm not sure that it is now, no. I know that it's been, I can only speak within the UK, and there have been various formulations and different agents, and they seem to wax and wane in popularity. And the other point slightly is that if a patient needs an injectable non-steroidal in the post-operative phase, it often implies we've missed something. So injectables tend to be opioid, and most non-steroidals would be oral within the UK, by and large.
Okay. There's a question here, again, doesn't say where it's from. Combination, it's talking about the combination of paracetamol and opioids, so they're available. Is there any study of efficacy comparing diclofenac and those combinations? And the answer is not directly that I'm aware of, and not much in terms of indirect either. There are some trials on paracetamol 1,000 milligrams and codeine 60 milligrams. And paracetamol 1,000 milligrams and codeine 60 milligrams single doses do reasonably well. But then diclofenac does reasonably well as well. That's not got the codeine in it. Are there any pain markers available for screening so we can choose a particular type of drug?
No.
Okay, that's
And
easy.
I don't think there ever will be.
Okay. A lot of health professionals combine NSAIDs. That one's gone. Where have they gone? That one's gone. Sorry. How long can we safely give analgesic for chronic back pains? This is from Kenya.
For as short a time as possible, because we know in the long term they tend to make no difference. So you can use one as a fire extinguisher briefly, but long-term analgesics for chronic back pain, there's an enormous question mark over it.
Well, one of the things, if I can just add there as well, one of the interesting things about chronic low back pain is that the amount of evidence, again, on how well drugs work is very, very limited indeed. And we've got some decent information on etoricoxib, on naproxen, I think, and on antidepressant begins with D.
Starpin?
No.
Duloxetine.
Duloxetine, yes. And they work in about 10% of patients.